Welcome to the lecture on cancer genes part 2. Mismatch repair genes. When the DNA proofreading fails, mutation slips through MSH2 and MSH6. The MSH2 and MSH6 are the guardians we can't afford to lose. The mismatch MSH2 MSH6 is the key mismatch repair genes in HNPCC pathway. MLH1 is the primary gene in hereditary colorectal cancer. So overall, MSH2, MSH6, MLH1 and PMS2 are all DNA repair genes. When there is a problem in the repair genes, then the DNA is not repaired properly, resulting in hereditary non-polyposis colorectal cancer. This can cause microsatellite instability, leading to colonic polyps and cancer. Neurofibromatosis 1 and 2. Imagine the nerves growing tumors like weeds. Neurofibromatosis is an example that shows what happens when growth control is lost. So neurofibromatosis 1, it is located in the chromosome number 17 and it is an autosomal dominant. They present with café-au-lait spots, axillary freckling, neurofibromas, CNS tumors including optic gliomas. The classic example is variable expressivity. That is, even with those with the affected neurofibromatosis gene, the disease severity will vary significantly. What about neurofibromatosis 2? That is located in chromosome number 21 and this is also autosomal dominant. So it will mostly present with acoustic schwannoma, some unilateral or bilateral presentation, and meningioma can frequently occur. Retinoblastoma gene. A single gene can blind a child to the world. RB1 failure lights the path to retinoblastoma. How? There are RB protein complexes with E2F transcription factor. When this complex is present, it will prevent cell cycle progression. Which one? RB protein complexed with E2F. But CDK cyclin complexes will phosphorylate the RB. Thereby, it will release the E2F for nuclear translocation. This E2F will enter into the nucleus and it will cause the production of many cells. So this free E2F will turn on the gene which is necessary for cell cycle progression. So what is that we need to know is when the RB gene is complexed with E2F, the cell cycle progression doesn't happen. But when the RB gene is phosphorylated, the E2F becomes free and the cell cycle progresses. So phosphorylation is bad. Phosphorylation will cause retinoblastoma. This is the key point we need to remember here. In addition, the congenital retinoblastoma will present with leukocoria in infants. That is the white reflex. Generally, when the light is shone, so you can even see like the red reflex in a camera, the pupil will be red. So generally the red reflex will be seen. But here when they are suffering from retinoblastoma, it will be a white reflex, leukocoria in infants. The retinoblastoma gene is also responsible for causing osteosarcoma later in their life. What about the RET proto-oncogene? The RET proto-oncogene can result in MEN2. One faulty switch in RET will trigger a cascade, unleashing the multiple endocrine tumors at once. So MEN1 is responsible, MEN gene is responsible for MEN1, whereas RET gene is responsible for MEN2. MEN2 will result in pheochromocytoma, medullary carcinoma, thyroid, while 2A will be associated with the parathyroid adenoma or hyperplasia, whereas 2B will be associated with the marfanoid habitus and mucosal neuromas. So these presentation can even be presented in isolation, and we need to find the syndrome behind it. TP53. It is the guardian of the genome. Once we lose TP53, then the cancer finds its way to the body. The P53, what is the role? Will sense the cellular damage and stress signals. It will halt the progression for allowing for DNA repair, and it will trigger the programmed cell death if the DNA cannot be repaired. So when there is a problem in this TP53, then it will cause multiple organ system cancers. And this is known as Li-Fraumeni syndrome. So what is the reason behind TP53? It is the failure of regulation of apoptosis. So this will exhibit pleiotropy, that is one gene, but there will be multiple unrelated different type of cancers being expressed. That is pleiotropy expressed by TP53. Tuberous sclerosis. Benign tumors in every organ, tuberous sclerosis teaches us what will happen when cellular breaks fail. So tuberous sclerosis will present with tubers. Tuberous sclerosis comes from the name tubers because it presents with periventricular nodules, tubers, and seizures from cortical hematomas. This will result in intellectual disability. In addition, adenoma sebaceum, which are basically angiofibromas, subungual fibromas affecting the nail beds, cardiac resulting in cardiac rhabdomyoma, presenting as a ball valve murmur with the positional variation, and renal angiomyolipoma. Benign tumors containing the blood vessel, muscle, and the fat. So all these are presentations in tuberous sclerosis. Similar to neurofibromatosis, this is also an autosomal dominant condition involving the hamartin and tuberin proteins. Von Hippel-Lindau disease. From hemangioblastomas to kidney tumors, von Hippel-Lindau shows how one gene can disrupt the multiple systems. Clinical triad is it can present with the retinal and cerebellar hemangioblastoma, and additionally with renal cell carcinoma, which can be unilateral or bilateral. This is the only one of the condition where pancreatic cysts can be frequently seen. This is the pattern which is seen over here in von Hippel-Lindau. The chromosome responsible is chromosome 3 and it is autosomal dominant inheritance. Wilms tumor, WT1 gene. A misstep in kidney development genes can turn a child's organ into a tumor factory. That is the role of Wilms tumor WT1. It will result in painless flank mass in a 2 to 4-year-old child because of the Wilms tumor. So it will not be present immediately during birth. Wilms tumor will develop only after 2 years. So during birth, what will happen? Or what are the syndromes that are associated with the Wilms tumor? So it can present, if the Wilms tumor is associated with gonadal dysgenesis, it will result in Dennis rash. If the Wilms tumor is associated with aniridia, genitourinary abnormalities, and intellectual retardation, it will associate with Wager syndrome. Beckwith-Weidman presents with fetal macrosomia, macroglossia, hemihypertrophy, hypoglycemia, and Wilms tumor. So this is what I told you. Wilms tumor will present only at 2 to 4 years. So they will be giving you a child with the macrosomic, macroglossia, hemihypertrophia, suggesting that it is Beckwith-Weidman, and they might ask what the born child will present. You should not come up with the answer Wilms tumor because it will occur only at 2 years. The child has the possibility of presenting with hypoglycemia. That should be the answer. Wilson's disease. Due to ATP7B, copper accumulates like a hidden poison. Wilson's disease reveals the use of ATP7B. So what it is? It is an autosomal recessive inheritance due to chromosome number 3 defect. Because of that, the copper cannot be secreted into the bile, and therefore it results in copper overload in the liver. This overload will result in an increased urinary copper, but there will be decreased serum ceruloplasmin. Why? Because serum ceruloplasmin is the transporter of copper. When there is excess of copper in the body, we don't want the ceruloplasmin also to keep transporting copper, right? So therefore the ceruloplasmin is decreased. Copper can get deposited in the basal ganglia, resulting in Parkinsonism in young patients. Can get presented in the eyes with presenting as Keshav-Fleischer rings on slit lamp examination. And obviously, it is present in the liver because only from the liver it has been unable to secrete into the bile, thereby presenting with elevated LFT with cirrhosis. The treatment for this is copper chelator, that is penicillamine. Cystic fibrosis due to CFTR gene. Cystic fibrosis or CFTR, one faulty channel mucus develops everywhere. CFTR mutation rewires the rules of lung and pancreatic health. The CFTR chloride channel is supposed to be present at the cell surface, facilitating the chloride transport. In cystic fibrosis, due to abnormal CFTR gene, there is abnormal protein folding. This CFTR chloride channel will remain sequestered in the rough endoplasmic reticulum and it doesn't enter the cell surface. So since the chloride transport is impaired, it will result in inspissated secretions in the alveoli as well as in the pancreas. So the secretions are all stayed within the lumen of the pancreas or in the alveoli and it doesn't go out. So therefore, because the secretions are all thick and sticky, therefore resulting in cystic fibrosis. The key feature is chromosome number 7. It is autosomal recessive and it is present in the delta F508 is the most common mutation. The delta F508 mutation will result in deletion of phenylalanine 508. But the gold standard is the sweat chloride test, where the chloride in the sweat has to be more than 60 milliequivalents per liter. So, what about the genetic testing? Genetic testing is not the gold standard because mutations in many other genes can also result in cystic fibrosis. Therefore, detecting only a delta F508 may not be reliable. The clinical features are it presents with chronic lung infections because of inspissated secretions. Early childhood, the gram-positive cocci in clusters, that is the Staph aureus, is the reason. After 10 years, Pseudomonas, which is gram-negative rods, is the main reason. The systemic effects are because of pancreatic insufficiency, inspissated secretion stays within the pancreas. There is exocrine pancreatic insufficiency. The pancreatic enzymes are necessary for the fat soluble vitamins to be absorbed. So fat soluble vitamins such as A, D, E, K are not absorbed. Vitamin E will result in a deficiency presenting with neuropathy. At birth, the secretions are inspissated, resulting in meconium ileus. So, and this is an autosomal recessive disease with a carrier frequency of 2/3 in siblings of affected children. With this, we have come to the last slide, that is Duchenne's muscular dystrophy. Muscles weaken, hearts struggle. Duchenne muscular dystrophy proves how a single structural protein holds our strength together. What? Duchenne and Becker both are X-linked recessive. So the problem over here is dystrophin mutation, which will disrupt the alpha-beta dystroglycan complex, therefore compromising the cytoskeletal anchoring. So the Duchenne's and the Becker, what is the difference? Duchenne presents with early childhood presentation, but Becker presents with little bit at a older age. So individuals with Becker will live for a bit longer time, but Duchenne's will present at a much early presentation. Both will be using Gover manure. The difference is the frame shift mutation seen in Duchenne, but non-frame shift mutation in Becker will preserve some dystrophin function, thereby the reason for the little bit later onset seen in Becker compared to Duchenne. The pathophysiology is muscle fibers are replaced with fibroadipose tissue, creating apparent muscle enlargement despite progressive weakness. So with this, we have come to the end of cancer genes. And this is the end of the cancer genes. I am Dr. Veena with a passion for teaching. If you like my videos and want to get mentored by me, if you are a medical graduate or USMLE aspirant, you are more than welcome. You can send me a message in the comments and we can take it forward from there. Have a good day.